and by speaking or chatting, you grant permission for us to record your actions. If you prefer not to be recorded, then you may want to disconnect now. I'm Kate Cross, and I will be your moderator today. Adriana Avalar will provide technical assistance for our session. We are both members of the WIN team, working with clinics in Eastern Washington Regional Collaborative and a statewide collaborative in their process of becoming patient-centered medical homes. For the webinar today, we will be holding most questions until the end of the presentation. We have two ways that you can ask questions. Up in the toolbar, you'll see a little man with his hand up. By clicking on him, it will raise your electronic hand, and we will be able to call on you to unmute yourself and to ask your question. The second way is to type comments into the chat box on the right-hand side of your screen. Questions here will be viewable by all attendees. If you're having a technical issue and you need to get something to just us, you can click on Adriana's name up in the participant list. Actually, she's the host, excuse me, in the host box at the top, and that will send it. You can choose private message, and that will send a message just to us so that we know that you're having a technical issue. With that, let's start the webinar. As mentioned, this is a WIN Collaborative monthly webinar. The WIN Collaborative has 8 key features that patient-centered medical homes incorporate. This topic supports 3 of those in particular: patient-centered interactions, organized evidence-based care, and continuous team-based health relationships. Today's agenda, we'll have an introduction, which we've done a good portion of. We have some speakers, Phyllis Cavens and Laura Porter, who are experts in adverse childhood experience. We'll follow that with a question and answer, and then with an evaluation. So let me tell you a little bit about Phyllis and Laura. Phyllis is a pediatrician in private practice in Longview, Washington at the Child and Adolescent Clinic, which she founded in 1978. There are now 9 pediatricians and 3 pediatric nurse practitioners at the clinic that provide comprehensive care and a medical home for 15,000 children. Dr. Cavens helped to develop the Children's Community Resources in 2000 and has served as its president for 12 years. Laura directs the Adverse Childhood Experiences Learning Institute for Foundation for Healthy Generations. She oversees an analysis of the ACE and resilience data from Washington youth and adults and works with local and state leaders to embed developmental neuroscience and resilience findings into policy, practice, and community norms. Welcome, Laura and Phyllis.
Thank you. So this is Laura, and I'm going to start out. And thank you so much for being on the webinar and for your interest in the subject of adverse childhood experiences. There is a whole bundle of science that informs transformational improvements in health, and we're living at a time where that bundle of science is getting larger and larger every day, every moment practically as we speak. And that bundle I think of as NEAR: neuroscience, epigenetics, adverse childhood experiences, and resilience. We're going to talk about that bundle today, particularly because primary care providers are trusted and knowledgeable people who come into contact with families in this kind of more universal system. So our knowledge of adversity during development is critical for our understanding of health risk, and the nature of our relationships with patients means that we're one of the most important first responders for working with this evidence in practice. So NEAR stands for Neuroscience, Epigenetics, Adverse Childhood Experience, and Resilience. And we'll start with those first 2 topics very briefly. The reason that developmental neuroscience is so important is just the nature of the way our brains develop. Brains develop sequentially and organized in a use-dependent fashion. So we all start conception with a relatively neutral starting place, and all of us have brains that are wired to adapt to experience. Experience literally shapes the neurons and the brain regions and the complex web of interactions among all of the neurons in our brain. And that adaptation invites a societal response. The cultural norms either provide supports and protection for people that are adapting to stress during childhood, or instead, those cultural norms can create a social isolation, rejection, other major challenges. And that sequence develops the pathway for health across the life course. Understanding how toxic stress shapes brain development is a critical pathway for helping to improve life across the life course. And really understanding childhood stress history equals understanding health risk in many, many ways. So in the neurodevelopment literature, it's clear that different brain regions have sensitive and critical developmental periods when they are extra sensitive to experience. For example, in the earliest years, the hippocampus, which is known for its role in learning and memory, and the amygdala, that's known for its role in the stress response, the HPA axis response, which floods the body with cortisol, are particularly sensitive to all forms of maltreatment in those first 3 to 5 years. And when maltreatment occurs, the actual function and mass of those brain regions in the limbic system are affected, and human beings adapt to that experience by being more able to navigate dangerous situations throughout their lives. Neuroscientists now have broad agreement that those changes to the brain regions that can result in people being more hypervigilant, more hyperresponsive, quick to anger or get into a very emotional state, very slow to soothe. Perhaps people have a response of being unable to be in a very rational discussion at the same time they're in a very highly emotional state. Those kinds of adaptations are not maladaptive. They are actually helpful to the species for survival, but they can be difficult on an individual throughout the life course in terms of their health and their relationships and their sense of emotional safety, their ability to regulate their own emotional states in order to fit into societal expectations. If we had more time, we could take time to talk about each of the sensitive developmental periods and the brain regions that are affected. But early childhood is not the only time when brain regions are very sensitive to toxic stress. Middle childhood, pre-puberty, and all the way in through early adulthood, we have sensitive developmental periods that are affecting brain regions like the right temporal gyrus. Once affected, has effects on profound depression and suicidal thoughts, and the corpus callosum, the superhighway that connects the right-left side of the brain and helps us integrate mathematics and language, highly emotional and rational states, and our artistic and logical thinking. Obviously, all of these brain regions are critical to the way we organize our lives and the way we function day to day in our relationships, our work, our families. They're also critical to our health status and the risks that come about in our lives. In addition to the neuroscience, we also are beginning to be more and more informed by epigenetics, the field of genetics that is studying how experience affects genetic expression. And epigenetics helps us understand how our life course in one generation can carry forward and affect the life course in the next. Just as a simple example, there were scientists that studied mischief of rats, and while they were growing up, those rats were conditioned to be afraid of cherry blossoms. When the cherry blossoms were introduced into their environment, they become terrified and ran to the corner of the confinement and shook in a heap because of the terror for cherry blossoms. Those rats had rat pups, and those pups grew up and had no exposure to cherry blossoms at any point, including in the womb. And then once those rat pups became adults, they were separated into a completely different environment, and cherry blossoms were placed into that environment. And those rat pups, now become adults, ran to the corner of the enclosure and piled on top of each other and shook in terror from the cherry blossoms. Now, why would that response be useful to the species? Well, it's extremely helpful if cherry blossoms were to be poisonous, for example, for fear and anxiety to be transmitted, in this case, through genetic expression to the next generation. It can actually keep us safe. It can keep us alive. So our bodies have these magnificent ways of adapting to stress and carrying those adaptations forward across the generations. Our understanding of this science can help to inform our work with patients and help them understand the health risks that they carry due to their experience. And that brings us to the Adverse Childhood Experience Study. The ACE study is an epidemiological study. It's a study of population health. So when we know about the adverse childhood experiences of an individual, we don't really know much about their health risk without having a conversation and learning more about how ACEs have affected them. But if we know about the ACE scores of 100 individuals, we know really a lot about the risk for that group of 100 people. So it's a population study, and this study is a partnership between Kaiser Permanente in San Diego with Dr. Vincent Folletti, who was in charge of preventive medicine at the time that the study originated there at Kaiser Permanente, and Dr. Robert Anda, who was a senior scientist at the Centers for Disease Control and Prevention in Atlanta, Georgia. At the time of the study, Dr. Anda had been working at the CDC's on heart disease prevention, and almost all preventive medicine research was oriented toward the top three rungs of this ACE pyramid. We were identifying health risks in order to reduce disease, disability, and social problems and prevent early death. And still, much of prevention science is oriented toward those top three rungs. But Dr. Anda, after working on the U.S. strategy for heart disease prevention, was concerned that he couldn't line up all the facts with that prevention effort because health risk is not randomly distributed throughout the population. He could see that something had to be driving the risk. So when he and Dr. Folletti shared stories of what they had been studying, Dr. Folletti had been studying preventive medicine and noticed that people most successful at preventing, at improving their health were often the very same people that would fall back into old patterns and their health then would decline again. And Dr. Anda had been studying heart disease prevention, had noticed this difference between the philosophy at the time about risk and the fact that risk wasn't randomly associated in the population. And so they theorized that adversity during childhood could be disrupting social, emotional, and cognitive development, and that disrupted development could be driving health risk in the population. The ACE study is a life course study. It's about conception all the way through death. And it's the largest epidemiological study of its kind. Over 17,000 people participated. These were Kaiser Permanente insured individuals in San Diego, so mostly middle and upper middle class, white, working individuals. And since that time, states have also measured adverse childhood experiences, and we have data from over 25 states now to confirm the findings of the ACE study. Since the Adverse Childhood Experience Study publications began to be read in peer-reviewed journals, the fields of epigenetics and developmental neuroscience have provided us with more information about the pathways and explanations about why adverse childhood experiences would be such a powerful influence on health risk and on disease, disability, and social problems and on early death. And the field of epigenetics has taught us a lot about why historic trauma and the patterns of adversity might be carried and be contributing to intergenerational transmission. But it's not just epigenetics that contributes to intergenerational transmission of adverse childhood experience. It's also the behaviors and the stressors and the difficulties that adults have in life that then affect the adverse childhood experiences in the next generation. In the ACE study, the scientists considered 10 different categories of experience. They looked at 5 indicators of family functioning, 3 kinds of abuse, and 2 kinds of neglect. So the indicators of family functioning: having a mentally ill, depressed, or suicidal person in one's home, having a drug-addicted or alcoholic family member. They looked at parental discord as indicated by divorce, separation, and abandonment. They considered domestic violence against the mother, and in the state's data, it's against any parenting adult in the household, and incarceration of a family member. And then they looked at 3 kinds of abuse: physical, sexual, and emotional, and 2 kinds of neglect: physical neglect and emotional neglect. Now, these scientists never thought that these would be the only kinds of stressors that could shape the development of human beings. Rather, they chose these 10 because they're in one domain. They mostly happen in the household, and because there's a lot of literature on how we prevent these kinds of things in family and community life. And so that combination made them a particularly powerful set of experiences to consider in the study. In the state's data, we've added adverse childhood experience study questions to the Behavioral Risk Factor Surveillance System Survey, or BRFIS, which is done in every state in the nation. And it's a partnership between the Department of Health and the Centers for Disease Control and Prevention. The CDC has very strict guidelines on what questions are added to state surveillance surveys, and the neglect questions didn't make it through the extensive testing process. So in the state's data, we only have 8 ACEs to consider. We have the indicators of family functioning and the 3 types of abuse. So when you see the original study, you'll see a total ACE score of 10, and in the state's data, you'll see a total ACE score of 8. So here are the major findings from the ACE study. One is those 10 categories of ACEs are highly interrelated. They found in the original study that among the people that had one category of adverse childhood experience, 87% had more than one. So it didn't make sense to continue studying these categories of adversity in childhood one by one, because they don't actually usually happen one by one. They usually occur in clusters. So they decided that they would study the clustering or the accumulation of adversity in childhood by creating an ACE score. So for each category of adverse childhood experience that people had in their lives, they got a score of 1, regardless of the severity or frequency of that particular category. So for example, if I experienced physical abuse during my childhood, I would have an ACE score of 1. If I experienced physical abuse plus emotional neglect plus I had a parent incarcerated, I would have an ACE score of 3. So it's the count of the number of categories that creates the ACE score. The scientists did consider frequency and severity, but found them to be less predictive of health risk and health outcomes. More predictive is this number of categories of ACEs experienced by individuals. And neuroscientists now give us some indication of why that might be true. One, because different kinds of experience affect brain development outcomes differently. So more categories probably affects more brain regions and affects them differently than having one category of ACE more frequently. And the other is that people that experience more categories of ACEs likely didn't experience them all in one year and then have childhoods with no adversity all the other times in their lives. So 2 of the different factors that neuroscientists find are driving the outcomes from adversity in childhood, the type of experience, and the age at which it occurs, are both covered in this way that the ACE score is developed in the ACE study. The second big finding from the study is that ACEs are common. Nearly 2/3 of adults here in Washington have more than one ACE. 27% have 3 or more, and 5% have an ACE score of 6 or more. Accumulation of ACE categories matters. The higher the ACE score, the higher the population risk for mental, physical, and behavioral health challenges, as well as social problems in the population. The ACE score meets all 9 tests for inferring cause and epidemiology, but for the purpose of slides and presentations, we tend to use the dose-response or graded relationship between the ACE score and population risk. So we all know dose-response. The more gas you put in your car, the more miles you can drive. In this case, the higher the ACE score, the higher the population risk for a wide variety of problems in the population. Again, I think it's important to recognize that adversity in childhood that triggers the fight-flight response of the limbic system and the HPA axis will shape neurodevelopment and may shape the expression of genetics. And so the 10 categories of ACEs are not the only kinds of toxic stress that are shaping development during childhood. But ACE scores are a good proxy measure for the dose of toxic stress that is occurring during childhood. It's highly predictive of health outcomes across the life course, and because of that, it's a very important measure for us to track and be aware of and for us to talk with people about. ACEs are the most powerful known determinant of health, and because they're the most powerful determinant of health, I believe that everyone has a right to know about the ACE study and should have an opportunity to discuss with a trusted advisor how ACEs have affected them and may be affecting their families. We see ACE is powerful not only in physical and mental health, but also in the social supports that make it easier to retain health throughout the life course. So now we'll have a poll and just find out for the participants, to what extent are you familiar with the ACE study? Not at all, somewhat, very familiar. Oh, perhaps you're already teaching about the ACE study or are an expert in it. We'll just wait a moment while you work with the poll. Can I view the votes? Okay. I think we must have all the votes in. So thank you very much. We've got a usual distribution of some people where the ACE study is new, most people that are somewhat familiar, and then many people, 1 in 5, that are very familiar or expert on the ACE study. So thank you very much for dialing in. And we're building our knowledge over more and more evidence coming from the ACE study, because the over 17,000 participants in this ACE study gave permission to the researchers to have access to their medical records throughout their life course. So there continue to be ACE study publications coming from the original study, and now many, many articles emerging from measuring ACEs in the population of adults in states. About 25 states now have added ACE questions to their behavioral risk factor surveillance system survey. This is a list of ACE attributable outcomes, and ACEs are considered to be the most powerful determinant of health because of the breadth of conditions that they're driving in the population, including risks for health problems, smoking, drinking, obesity, behaviors that create risk for AIDS, using drugs and other, using drugs and alcohol, and obesity. ACEs are also driving the rates of poor mental health, including really all of the major diagnosable mental illnesses, and also conditions that are emblematic of mental health challenges like sleep disturbances and distress. ACEs are driving all the major causes for disability and disease in the population, and one of the biggest alerts that happened when the ACE study began to be publishing articles was that adversity during childhood is driving diseases like cardiovascular disease, cancer, asthma, diabetes, etc., where people knew that more adversity in childhood probably was making life harder for individuals, we didn't necessarily know that it was actually driving the rates of these physical diseases that affect the population as a whole so deeply. ACEs are also driving health and social problems, and many of these health and social problems we couldn't find out about in the original ACE study because of the population sample that they were working with being insured, employed, upper middle class. But when we added ACE questions to the Washington Behavioral Risk Factor Surveillance System, we were asking these questions of the general public. So we were able to look at whether ACEs are driving unemployment, homelessness, incarceration, etc. And what we found was profound impacts on people's limitations in the quality and functioning in their daily life and their ability to complete secondary education, and unemployment, homelessness, and incarceration. We also added to the Washington data the 5 conditions for adults that become ACEs for the next generation, because we wanted to be able to look at intergenerational transmission of ACEs in the population. So we added these 5 intergenerational transmission ACEs so that if the adults answering the telephone call in the BRFIS had a mental illness, a drug or alcohol problem, had divorces or separations, was a victim of violence in the family, or had been incarcerated as an adult, if there were children in that household, we can see the intergenerational transmission of ACEs in the household. So in Washington, we're able to look at the transmission of ACEs as well as the effects of ACEs on health. ACEs are highly predictive, the ACE score, is highly predictive of individual health outcomes. It's also highly predictive of co-occurring health problems throughout the life course. And this slide is used with permission from Dr. Robert Anda, co-principal investigator of the ACE study, and comes from the original ACE study data. So Dr. Anda looked at a list of health and social problems that represent different body systems from affect, somatic, to substance abuse risk, sexuality, memory, and arousal, and looked at the relationship between ACE score and health and social problems from this list. And what he found was that among people with 0 ACEs, the mean number of co-occurring outcomes from the list on the right of this slide was 1.5. But among people with very high ACE scores of 7 and above, the mean number of co-occurring outcomes was 4.5. So what we find is that ACEs are driving co-occurrence of problems that are affecting multiple body systems at any given time. And this makes life harder, and it especially makes parenting harder and increases the risk for intergenerational transmission of ACEs to the next generation. Just imagine if you had problems with substance abuse, with affect regulation, with memory, and with your arousal and ability to self-soothe and calm, how much more difficult it would be to parent well. Those are the kinds of struggles that adult patients in your practices may be facing, and unfortunately, many people with co-occurring problems also carry a lot of shame. They think they shouldn't have these responses when actually these kinds of responses are normal adaptations to toxic stress during development. We can't necessarily reshape our physiological response to stress. What we can reshape is what we do about that response to stress. So our support for patients in being able to talk about their experience and being able to talk about how they're navigating adult life given how they have physiologically adapted to ACEs, those conversations can be really powerful in helping people navigate life well. ACEs are also considered to be the most powerful determinant of the public's health because of how much of each of these conditions is attributable to the ACE score. ACEs are driving large percentages of major cost centers in the public and the private sector. And so in Washington data, we've been able to look at the population attributable risk for all of these and more kinds of challenges in the population. So this slide, in the center of the slide, we made this image for the first time right after the Gulf oil slick. So the center represents, we thought of it as an oil slick image. And it represents the portion of each of these challenges that are attributable to adverse childhood experience. So we'll just mention a few of these. 61% of incarceration as an adult in Washington is attributable to ACEs, 22% of recent falls, 31% of current smoking, 31% of drinking and driving, over 50% of high-risk behaviors for HIV, 15% of insulin diabetes, insulin-dependent diabetes, 17% of asthma, and you can read all the way around. The largest population attributable risks associated with adverse childhood experience are suicide attempts and IV drug use. Almost no one with an ACE score of 0 actually takes a needle and injects drugs into their veins, but many people with high ACE scores fall into patterns of adaptation that make them more vulnerable to drug use and to other kinds of risk behaviors that affect their health. In communities across Washington, there are coalitions from many sectors that are beginning to get together and work on reducing and preventing ACEs in the next generation. Just wondering, to what extent do you know of groups in your community that are focused on using the science to improve child well-being? From this poll, we're trying to get a sense of how integrated our different sectors are in working together to prevent ACEs in the next generation and to mitigate their effects in this adult generation. Still picking up a few more votes. Okay, thank you so much. So about 40%, that seems like quite high. Tells me that primary care providers are pretty involved in leadership roles, and that's so important because primary care providers really are the first responders in our system, and really very important that you're involved not only in your practice but also in helping to co-lead community efforts for prevention cases in the next generation. So thank you. In Washington, we have gathered enough ACE data now to begin to be able to make geographic maps of the concentrations of high ACE scores. We have 3 consecutive years of adverse childhood experience data from Washington adults, and that allows us to have a large enough sample size to make maps like the one you see here. This is a map of the concentrations of people with 6 or more ACEs, very high ACE scores, and the Washington population as a whole, about 5%, or the darker of the 2 green colors is the state average for having 6 or more ACEs. And so you can see areas of our state that have 4 times, close to 4 times that rate, that are in the orange areas of the state, double the rate in the yellow. And when we have very high concentrations of high ACE scores, we might see people that are struggling more with all different kinds of challenges in their lives. In fact, one of the scripts that home visitors are beginning to use is to talk with folks about ACE history and listen to how that history might have affected them throughout their lives, and then ask. Many people with high ACE scores find lots of things in life to be more difficult. How have you done so well? When we listen to the ways that people have navigated their lives and found ways to do well in the face of this adversity, we can find those threads of resilience that we can weave through our practices and help to support them in doing well in their health throughout their life course. So this act of asking and listening and then affirming, I'm glad you're my patient, or these are incredibly impressive skills that you've gained to do well in the face of this adversity. I'm proud of you. Asking, listening, affirming, and then remembering when the patient comes back in that this is a person who is navigating challenges and is coming to you for support in that navigation. Many people with very high ACE scores find it surprising when people remember that they have had challenges in their lives. And they're relieved that they don't have to tell their story over and over, but rather that they're building a relationship with somebody who remembers and cares and wants to talk about how adversity is affecting their navigation of life. Here's a map of the concentrations of a population with 3 or more ACEs. And you can see the areas in Washington. Again, the orange areas are the highest ACE prevalence in the state, the light green, the lowest prevalence, and the state average is 27%, so right on the line between the darker green and the lighter blue. We see big chunks of Washington state that are higher than the prevalence, higher than the average state prevalence. So one of the ways that having these maps is useful is just looking at ACEs reliably predict the need for health services, and so we can look at where there are physician scarcity. For example, the blue areas on the map on the right are specialty physician scarcity, and the green areas are both physician scarcity and specialty physician scarcity. And you can see that some of the very same areas in Washington where we have very high ACE prevalence, we also don't have enough primary care providers. And so that means we may be seeing a flooding of emergency room use in those areas. And we may need to take more care with how we're preventing emergencies in the population through peer supports, community health workers, and other kinds of supports in the primary health care world. So what we've noted in the Washington data is that having a higher ACE score is predictive of more health challenges. Having ACEs plus major adult adversities adds to that burden. And what we did here was we looked at the percentage of people for whom 15 to 30 days out of the last month they couldn't do their usual activities, so it's a measure of functioning. And everybody represented in the bars have 3 or more ACEs, and along the bottom we see 3 or more ACEs plus 0 adult adversities from the list at the left, 3 or more ACEs plus 1 adult adversity from that list on the left, 3 or more ACEs plus 2, and 3 or more ACEs plus 3 adult adversities. And what we see here is when society essentially turns our backs and allows the very same people who experience the most adversity during development to be the people who also experience tremendous challenges during adulthood, we see this huge impact on functioning, where only 4 or 5% of people with 3 ACEs plus 1 major adult adversity are having difficulties functioning during their month. That number goes to 17.5% with 3 or more ACEs plus 2, and 58% of the population with 3 ACEs plus 3 major adult adversities are having difficulty functioning for half to all of their month. That may be the reason that people are having trouble showing up at appointments and also make parenting much more difficult. So we know from statistical modeling that we've done with the Washington data that a highly powerful strategy for us to consider is to moderate the effects of ACEs among parenting adults, especially those with high ACE scores, in ways that help those parents to prevent ACEs among their children. Parents are the most powerful people for preventing high ACE scores for the next generation. And when we're successful in doing this, we set up a virtuous reinforcing cycle where we have fewer ACE effects, which reduces the ACE score. A lower score then will in turn reduce ACE effects. This is a powerful cycle for improving health over the generations. Washington has the best data in the nation. We've looked at ACEs, we've looked at adult adversity, intergenerational transmission, and we've also looked carefully at resilience factors from the literature and started to measure those factors in the Washington population. So among adults, we've looked at different kinds of help that make a difference in mitigating the effects of ACEs. And two factors from our factor analysis. One is feeling socially and emotionally supported and hopeful, that internal feeling about one's life and relationship with others. And the second factor is having two or more people who will actually show up in person, not on Facebook, but in person, and give help when it's needed. And I just want to show you the kinds of effects that those factors have on physical health and mental health. So this first set of slides I'll talk through slowly, and then I'll move through because you can see very rapidly from the pattern how these resilience factors are helping adults with their health status in Washington. So this is a chart of people who reported having low levels of social emotional support and hope, and it's about physical health status. So these are people who said they had poor physical health more than half of the last month and low support and hope. And you can see this dose-response relationship with ACE scores. The higher the ACE score, the more the larger the population with poor physical health. But look at the people who report having high social emotional support. That percentage of the population with poor physical health drops dramatically in the population. And let's look at mental health, and with support, this huge drop in the percentage of population who report having poor mental health more than half the last month. We'll look at having two or more people who give concrete help when needed. I'm just going to show you a couple of indicators. Poor physical health, this big drop, and mental illness. This is using the Kessler score, which is the best set of indicators for mental health symptoms. So people may still have a mental health diagnosis, but they're much less likely to be struggling with mental health symptoms using the Kessler score as an indicator. So we're also measuring two kinds of community-level resilience. One is reciprocity, the way people are interacting with one another in communities, as indicated by whether people normally are watching out for children, intervening when kids are in trouble, and whether adults normally do favors for one another. And we're also measuring the hardest kind of social capital to build in a community, which is social bridging. This question is, imagine the circle of people that you rely on for help and support in your life. How common is it for one of those people to reach outside the circle to get help for someone inside the circle? Social bridging weaves a strength in the community because it allows groups of people perhaps who have very high ACE scores, who might be struggling with their daily lives in various ways, to reach to other circles of people for help and support, but also to reach to other circles of people to give. No one likes to be on the receiving end all the time. And while I can't give you bar charts yet because we're just looking at the second year of data here, I can show you that communities with high rates of reciprocity and bridging have better rates of obesity, mental illness symptoms. They have lower alcohol consumption among parenting age women, better physical activity rates, better happiness, less worry about money for rent. They're more likely to have a primary care physician. They're less likely to experience housing instability and less likely to be hungry because they don't have enough money. And this is an important list because it represents both health status, which the other two resilience factors are associated with better health status, but this is better health status and better health behaviors. So we think the combination of all four factors will produce dramatically improved health results because they will boost health status and health behaviors. So as we're talking with people in our practices, we can be asking about who do you have to rely on for help when you need help? How are you feeling with social emotional support? What helps you experience social emotional support? And helping people build the kind of social networks that are powerfully important for improving health and well-being across the life course. And with that, I want to turn to Dr. Phyllis Cavens, who will talk about working with this science in a medical practice. Phyllis?
Thank you very much, Laura, and thank you all for coming to this webinar and giving me the opportunity to discuss with you medical home and ACEs. The medical home system of care is family-centered, community-based, and physician-led, and cares for the whole child during the entire neurodevelopment trajectory to adulthood. With medical homes and ACEs, we have two goals. Number one, a medical home for all children in a high ACEs community with high ACEs parenting adults. And number two, identify children with issues resulting from violence and toxic stress and connect the child and their family to the resources needed to heal and to continually move towards a positive future. In a family-centered medical home, the target is the parenting adult nurturing a child. In a community-based medical home, all resources and supports that are needed are available. In a physician-led medical home, there is a pediatric primary care clinician who is the trusted messenger for a child exposed to or victimized by violence. The clinician in a medical home may be one of a few safe, reassuring relationships a child or youth may have. In a medical home, clinical care, family care, and community care come together. The medical home care team coordinates, co-manages, communicates a common care plan for the child and their family. The care team can be physically and virtually co-located to integrate physical and behavioral health. The human need for relational affirmation. Every human interaction in your clinic, your community, your child-serving agency, organization, or school is an opportunity for kindness and understanding. A director of a shelter and recovery program for homeless mothers and their children described it this way: I believe the greatest poverty is the poverty of relationships. Having others put you down because of your circumstances or behavior only deepens the poverty of an individual. Having positive relationships increases the richness of personhood that overcomes other barriers to personal and financial success. The American Academy of Pediatrics mission statement contains this: children have optimum health and well-being and are valued by society. This raises the questions: are children losing the foundations of health and well-being? Are we valuing children the way we need to be? Dr. Sandy Hassink is the president of the American Academy of Pediatrics, and she states this challenging response to the above questions. We as a nation need to value our children enough to shift our spending priorities and embark on initiatives to ensure that families and communities have the ability to build a strong foundation in the early years for a lifetime of good physical and mental health. An investment in early childhood health, education, and social supports for all children may well be our most important effort over the next generation. It will generate profound returns. The parenting age adult has stressors and community supports to build resiliency that is mutually reinforcing with their child. Ideally, the parenting age adult chooses a physician in a medical home as a partner to nurture their newborn until adulthood, to ensure the optimum health and well-being of their valued offspring. The parent shares the stressors in their life and in their family. The physician becomes the repository of this knowledge of stressors over the years of the parent's educational, employment, social, emotional, and behavioral successes and failures. In short, their ACE score. The physician is knowledgeable of the community supports that the parents need and the challenges and barriers to utilize and engage in services and supports. Together, the parent and the physician strive to build resiliency so that the high ACE parent can nurture a low ACE child and interrupt the intergenerational high ACE cycle. Community ACEs predict youth risk. The rate of adults with greater than 3 ACEs in a community powerfully predicts child academics and risk. We know that in high ACE communities, youth are more likely to be kicked out of school, and when in school will have lower test scores and lower levels of social skills needed to succeed in school and adulthood. There's a predictive value of the youth ACE scores in schools. As the scores increase, the standardized test results in the 10th grade are significantly lower. The reported risk behaviors are significantly higher. While poverty continues to be an influence on youth well-being, it is the community and youth ACEs that are more consistent predictors of youth well-being. And to repeat the slide that Laura has presented regarding this virtuous cycle for health, we can, if we'll add to this, well child care and behavioral health screen as a mutually reinforcing endeavor that we can, as clinicians, add to the mutually reinforcing cycle. Instead of breaking the cycle of high ACEs, we might think of making the cycle of ACE prevention by providing well child care and behavioral health screening. As clinicians, we can promote optimum development by providing comprehensive well child preventive system of care with anticipatory guidance and early intervention. We can help the patient and their family and their parents have better parenting. During the first 1,000 days of brain development, we provide 10 well child visits and developmental screening. At the 3, 4, and 5-year-old well child visit, we can provide social and emotional screening, so that there is early intervention and early identification of developmental social-emotional problems, intervention that will ensure that the child enters kindergarten healthy and ready to learn. At yearly well-child visits for the school-age child, we can provide behavioral health screening and also provide substance abuse screening for all adolescents. In the medical home, it is an imperative that we perform yearly behavioral health screening because of the following list of statistics. The rate of disability relating to physical conditions has decreased over the past 10 to 15 years, as the rate of neurodevelopmental and mental health conditions have increased by 21%. At any given time, 11 to 20% of U.S. children have a behavioral or emotional disorder. 38% of children will have a behavioral or emotional diagnosis by 16 years of age. Developmental and behavioral health disorders are now the top 5 chronic conditions of children. 50% of adults with behavioral health problems report that their disorders started in their early teens. There is a 2 to 4 year period between mental health symptoms, appearance, and mental health diagnosis. In 2010, 1 of 5 children were reported to be living in poverty with increased exposure to environmental, familial, and psychosocial risk. Fewer than 1 in 8 children with identified mental health problems receive treatment. Fewer than 1 in 3 children with mental health problems are identified in primary care settings due to the lack of behavioral health screening. In the state of Washington, every 2 years, a Healthy Youth Survey is performed for all children enrolled in grades 6, 8, 10th, and 12th grade. On the survey, there are 248 questions regarding physical health, behavioral health, safety, health risks, behavioral risk, and protective factors. The results are reported by county and statewide. The test is taken anonymously with no resulting referrals or follow-up or tracking of the results. In our county, Cowlitz County, the results parallel and are slightly worse than the state average. In 2012, depression, the percentage of students who reported experienced depressive feelings in the past year were consistent for grades 8, 10, and 12 at 30%. Contemplation of suicide. The percentage of students who reported having seriously considered suicide in the past year were consistent in 8th grade, 10th grade at 20%, 14% in the 12th grade. With the question raised, did the depressed children already drop out of school? Current binge drinking. The percentage of students who have drunk 5 or more drinks in a row in the past 2 weeks. In the 8th grade, 8%, 10th grade, 17%, 12th grade, 20%. We need to be proactive with yearly behavioral health screening and early intervention so that in the medical home, where the pediatrician or pediatric primary care clinician is the trusted resource for advice and parenting care for each child, we must be able to screen, early identify, and have early intervention and care for children with behavioral health and mental health symptoms. Schoenkoff used the phrase toxic stress to describe high accumulative psychosocial risk in the absence of supportive caregiving. This type of unremitting stress ultimately compromises the child's ability to regulate their stress response effectively and can lead to adverse, long-term structural and functional changes in the brain and elsewhere in the body. The American Academy of Pediatrics has published in the below link an article entitled Early Childhood Adversity, Toxic Stress, and the Role of Pediatrician, Translating Developmental Science into Long-Term Health. And I refer you to that article for a more in-depth look at our role in caring for children. In response to this also, there's a link to the American Academy of Pediatrics Resiliency Project, which is a set of a toolkit of how we can address building resilience in our children. There is a concept that if a child had a web of support of 5 caring adults for support and hope in their childhood, that would be adequate to provide resiliency to the stresses they encounter. Excuse me. In the state of Washington, the Department of Social and Health Services, Behavioral Health and Recovery has grants available to individual communities to present the USA Youth Mental Health First Aid course and training. It's an 8-hour public health education program for adults that interact with adolescents. It's for teachers, coaches, leaders from the faith community, the YMCA leaders, club leaders, social workers, neighbors, concerned, caring citizens that want to be involved with the adolescents and want more skills so they can offer support and hope to our youth. The community of support should come to the aid of children and their families in the areas of home instability, food scarcity. Where do people sleep? And how do they keep warm? The basis of support of our community. As clinicians in primary care, we have the opportunity and the responsibility to be an advocate for our children in our community as they look how to support our children, and in advocating for opportunities for training such as the Youth Mental Health First Aid Training USA. Thank you.
I'm seeing a few questions coming in, and as we talk about those, I want to point out a couple of more things about our actions regarding adverse childhood experience and our understanding of this bundle of science we call near science. We've got somebody asking if there's a Spanish language ACE questionnaire. The term ACE questionnaire is an interesting one. In the original ACE study, there were over 70 questions that came from the literature on these different adverse experience categories. In the household survey of adults, we have a set of 11 questions that we ask in order to identify 8 ACEs in one's history. And then Dr. Robert Anda has developed a 10-question form that he uses with lay audiences to help people identify their own ACE scores. So the question that was typed in was, do we have available in Spanish language? And the answer is yes. Both the BRFIS, the household survey set of questions, and the 10 questionnaire are available in Spanish language. I don't think I have them in my own electronic files, but I could get them and send them to Department of Health for distribution. But I want to point out that asking about a person's ACE score is certainly not the only kind of action we can take using this science. All aspects of practice can be informed by the near science, everything from how calming the reception area is to whether we are having appropriately welcoming kinds of relationships with patients and clients, all the way to whether we have reflective supervision that is supportive of staff, because ACEs are common. They're common among our staff, among ourselves as professionals, not just among our clients and patients. So near-informed action can range from the way we supervise our employees to the kinds of environments we establish, to the schedules, whether we allow for drop-in kinds of services as well as scheduled services, all the way to the affective kinds of relational experiences that we set up in our practice. When we ask directly about ACE history, I think it's important to note that ACEs, it's not a quiz, it's not a test, it shouldn't be used as a qualifier for services. The ACE questions are not an assessment. They are a person's personal history. And so really we're talking about learning about the person's history and having a conversation. How have these experiences affected you in your life? And what have you found that helps you do so well? Having said that, I see Cecilia asking this question about when you have a conversation with someone who has a drug addiction problem about their ACEs, how do we better involve people in engaging them and making different, choosing different kinds of ways to cope and accommodate for their physiological response? And what we have seen over and over and over is that once especially parenting adults understand and think about how ACEs have affected them, they can understand better what their own response to stress might be. They may or may not choose to stop using right away. They may choose other ways of recasting their own narrative about their lives. And so our job is to help find their hope. So hope requires three different factors. It requires imagining that there could be a better future. It requires seeing that there's a pathway to that future and that I could be on that pathway. So I think a practitioner can help to lay the groundwork for all three of those, helping the person identify the future that they might want for themselves or their children or their grandchildren, and then helping them identify the pathway to that, which may or may not be the exact action that we are hoping they'll take. We have to allow them the dignity and honor of deciding their own pathway to help to prevent ACEs in the next generation. Most of the practices that I know of that have begun to ask questions about ACEs spend a considerable amount of time first adopting reflective practice with their employees and learning about the science, as well as making sure that there's vertical alignment all the way through the clinic or system that you're working in, so that managers and leaders in the organization are supportive of the change. And I think that's really critical, that we invest in readiness to use the science. And Phyllis, what would you like to add to my ramblings there?
I'd just like to comment, it's in pediatrics, and I'm sure in family practice, it's very common to do a family history and including the social history. So you don't necessarily ask a list of ACE questions, but you do ask about the social history of the adults in the family. So that becomes part of your record. And then as you are following the child's growth as the child grows older, in your interaction with the family, you do discover their educational, employment, social, emotional, and behavioral stressors and successes. And that gives you insight into the ACEs in the adults that are caring for the children. I noticed that Barb Kluwer asked about what is the mental health first aid. I included a link in the PowerPoint slides that will take you directly to mentalhealthfirstaid.org. And essentially it's been offered in our community at one of our smaller school systems, and invited the community to attend an 8-hour class about how can adults interact with adolescents to provide them support and hope. And so I'm going to, as an advocate for children in our community, try to get each school district to sponsor this class, and what a way that could really raise the level of support and a path of hope for the adolescents in our community.